week, Surfing the MASH Tsunami brings you three major stories from the world of steatotic liver disease. This weekend, we're bringing you each of these stories separately so you can listen over a shorter, discrete period of time. Hope you enjoy them.
For the last 5 years, MASS-LD stakeholders, whether manufacturers, trial sites, providers, payers, patients, or investors, have turned to surfing the MASH tsunami to keep track of drug and device development, epidemiology, public health initiatives, and practice patterns. This weekend, we are sharing the three main sections from our episode 11. Roger will provide more information after these notes from our sponsors.
Surfing the MASH Tsunami is sponsored by these healthcare-related organizations.
Regeneron is a leading biotechnology company that invents, develops, and commercializes life-transforming medicines for serious diseases. Founded and led by physician scientists, their unique ability to repeatedly translate science into medicine has led to numerous approved treatments and product candidates in development, most of which were homegrown in their laboratories. They are shaping the next frontier of medicine with data-powered insights from the Regeneron Genetics Center and pioneering genetic medicine platforms, enabling them to identify innovative targets and complementary approaches to potentially treat diseases like obesity and MASH.
LiverRight and the LiverRight Scanning Network. LiverRight is America's first virtual specialty clinic for liver disease, offering adults in all 50 states video appointments and helping GI practices and health systems triage and treat the swelling numbers of patients seeking MASLD and MASH testing. LiverRight offers same-week video visits and accepts insurance. For more information, contact LiverRight. That's liver then R-I-G-H-T as if one word, at www.liverright.com.
Tawazun Health, your partner in global liver health innovation. At Tawazun Health, we specialize in providing small or large-scale access to FibroScan examinations for liver health-focused early detection, clinical trials, independent research, and collaborative projects with clinicians and FibroScan providers, now in over 30 countries around the globe. As industry-leading experts, we design and deliver high-quality FibroScan services because we know that accurate, high-quality, reliable data drives better outcomes. To learn about Tawazun Health or our sister lifestyle app, mylife365.me, click the Tawazun Health link on the Surfing MASH homepage. This week concludes with our expert interview. Louise Campbell and Roger Green interviewed Dr. Emily Andaya, Medical Director of the Cardiovascular Program at Major Health Partners in Shelbyville, Indiana, and a leading advocate for including the liver as a key element in multi-metabolic health programs.
This week's expert, Dr. Emily Andaya, is the medical director of the cardiovascular program at Major Health Partners and Major Hospital in Shelbyville, Indiana. She joined our podcast earlier this year to talk about her belief that liver was not given its appropriate role in the general focus of multi-metabolic diseases, specifically the American Heart Association CKM initiative. She talks about that in greater detail here. She starts by talking about a speech she heard previous weekend, actually, at the American Society of Preventive Cardiology meeting from Dr. Christos Montzoros of Harvard, proposing that the liver's role in cardiovascular diseases is equally critical when compared to the kidney or other multi-metabolic comorbidities. Dr. Montzoros closed this talk by proposing specifically that the CKM designation be changed to CKLM, the point that Emily had been making in previous episodes. She goes on from there to describe the scoring system used in the CKM initiative, which is not identical to the fibrosis scoring or NAS scoring systems used for MASH and MASLD. But she explains how the two can be integrated in ways that will be helpful for patient treatment. At that point in time, the conversation shifts to focus on patient management, and specifically after you explain what's going on with the scoring. And here, her points are highly instructive. This week, our expert interview is with Emily Andaya, who you folks met earlier in the year when she talked about how to focus a primary care practice on multi-metabolic issues. This is going to be a slightly different conversation. I think it's going to touch on a lot of the same things. Louise is with us today. Emily, how are you today?
I am doing good. I am tired, but I made it from Boston. And my mom is upstairs in the inpatient. She just had her total knee replacement. So it's been a busy day.
Yeah. Yeah, it has been. It has been. Actually, the last time I interviewed you, you were in Hawaii the day before you were flying home from vacation.
Yes.
So either you live a total jet set life, or I seem to catch you at all the right moments.
You just catch me at the right moment.
Okay. Louise, how are you today?
I'm very well, thank you very much. And it's lovely to meet Emily across the screen, and apologise for her having to listen to me in the past.
Okay. Simple groundbreaker. One good thing that's happened in the past week. Emily, you just gave us at least two, but you can start wherever you want, and we'll just go from there.
I think I just want to share what happened to my last conference, and I think it is a really good conference. It's a conference of the American Society for Preventive Cardiology. We call it ASPC. And the conference is also known as CVD Prevention Congress, and we held it in Boston. So just as an overview, ASPC is an organization primarily made up of cardiologists, but it also welcomed endocrinologists, nephrologists, primary care practitioners like me, and those who are interested and devoted to advancing the cardiovascular health. At the Heart Congress, they talked heavily about standard modifiable risk factors for prevention of cardiovascular disease. That includes hypertension, hyperlipidemia, and also what's important is the non-traditional risk factors like lipoprotein(a), high sensitivity CRP, and highlighting the emerging role in personalized prevention strategies. They offer a lot of learning experiences for the attendees like me, wherein we explore established and novel treatment modalities, some not yet embedded in clinical guidelines. So when you listen to them and you talk to other people, you sound like you're really smart. But for years, they have focused on cardiovascular prevention conferences that revolved around the relationship between kidney disease, heart health, and metabolic disease, and the role of excessive adiposities in all of these diseases. But this year, ASPC took a bold step and invited Dr. Christos Montzoros. He was invited to speak, and he challenged the conventional boundaries by emphasizing the liver's equally critical role in cardiovascular disease outcomes. His message resonated deeply with me, echoing the perspective that I've long believed that deserves greater attention. He talked about taking care of the patient as a whole. Taking care of the heart and the kidney is important, but we should not forget about the liver because we want to take care of the whole patient, and the liver is included on that whole patient. So I remembered he was also there in that conference when the author of the American Heart Association Presidential Advisory, CKM syndrome, and the author explained to us what a CKM syndrome is and the benefit of that and the role of that excessive adiposity with the kidney and the heart. But there's a picture of the liver on that pathway as well, but that wasn't mentioned. And so I questioned, and I'm shy, but during that time I stood up and I said, I don't understand why the picture of the liver is so small in that diagram. Is it because when it's diseased it's not that dangerous, or it's because it's the smallest organ in our body, which is not the case? And it's clearly there in the diagram, kidney, heart, and liver, but why is it just CKM and not CKLM? And I told the speaker that I know because I learned from Dr. Montzoros, and I know he was there, and he told us about the importance of the liver and that ASCVD pathway, and they told us the reason why it's not included. But even if the session has ended, Dr. Montzoros stood up and he said, I really would want you to consider to include the liver on the CKM. I just want you to reconsider. So now on his talk, he said, I do believe that it should be CKLM and not just CKM. So I'm not the only one. He has my back on that.
Actually, the day that I met Emily when she was speaking at AASLD and stopped to ask, why did you come to this meeting? beginning, what she was talking about was exactly this, the idea that it was CKM instead of CKLM, and how myopic that was, to use a completely unrelated organ, the eyes, how myopic it was. So what's happened next?
So they agreed with that as well. But now also, I think there's more people who's agreeing to that. And I'm hoping that American Heart Association will be open to that as well. But I mentioned about the CKM syndrome, and I think it is very important that we talk about this, because I think that this is going to be a good tool for all of us to move forward in the same direction. So American Heart Association, what they wanted to do in this CKM construct, their recommendation is to stage all of our patients in their whole lifetime. So stage 0 is when your weight is normal. Okay, you don't have any cardiovascular diseases, and I tell my patients probably when you're in high school, that's where you're at. And stage 1 is you already have an excess adiposity. So for Southeast Asian, our BMI cutoff is 23 and 25. So if you're already above those cutoff, you're already on stage 1. And if you already have prediabetes, you're already on stage 1. And then stage 2 is when you already have those other cardiometabolic risk factors like hypertriglyceridemia. Take note, triglyceride more than 135. And if you're going to think about it, which are the persons that has slightly elevated high triglycerides, they are the ones who are insulin resistant. They are the ones who have cardiometabolic diseases. So if you already have hypertension, hyperlipidemia, are already on stage 2. And stage 3 is when you already have subclinical cardiovascular disease. So when you have your heart scan and you already have a plaque, then that's subclinical cardiovascular disease and subclinical heart failure. The problem with this stage is you will not know that you're there unless you look for it. And stage 4 is when a patient already have a heart attack, stroke, and if a patient already had atrial fibrillation, and if the patient already have a heart failure or peripheral artery disease. Now, I'm sure you've heard about people who just died of a sudden heart attack at the age of 50 or 40, and they say out of nowhere. But the truth is, it's not really out of nowhere. They've been battling this for a long period of time, and it's only then that they have found out because the risk factors were missed. But now, if we are going to stage everybody, then we can have the opportunity to act on those risk factors.
Let me slow it up.
Yes.
Let me take a break. Let you catch your breath, get a sip of water. Louise, questions, comments, thoughts?
I'm loving it.
Yeah.
As you'd expect.
Part of it is we're both going. You go, girl.
Absolutely. But I do think this is, when I was reading the document, I was leaning towards that. We need to be assessing people's cardiometabolic state at stages through their lives, because the earlier we find these conditions and related conditions, the more we can do in prevention. If we find fatty liver in somebody who is in their teens, early 20s, we can talk about diet, we can talk about lifestyle, we can look at prevention, and we do have non-invasive diagnostics now that allow us to put the story together in a better way. And I think this whole thing of managing somebody, metabolic syndrome is the biggest condition globally. It is the biggest killer. It is the biggest all-cause mortality. If we did a survey in a hospital today, we're going to find a massive amount of patients in every ward with steatotic liver and multiple factors for cardiometabolic syndrome. So it really, really resonates with me that if we can get these sort of systems in place nationally, that somebody is checked out preventively or where they've already developed it by a certain stage, because we're going to have to start somewhere and they've already developed it. But I think it's a great thing. And I think Russia do something similar. They assess at 18 and then they assess somebody's physical fitness at 30 is the next time point, I think. So they do stuff, but I don't think it's just cardiometabolic. I think it is just a general health screen. But I love it. And the more we get together as organizations, we're all saying the same thing. Early detection helps. We're all asking for the same thing. So, Emily, fill your boots. I'm in there with you.
So this CKM construct is inclusive, wherein now all patients needs to be evaluated with their kidney function that includes urine albumin creatinine ratio. And so even if the creatinine is normal, but then they're spilling protein already, they're already classified on that CKD, which is the stage 2 and 3. But listen to this. So since I've been obsessed about this, so I tried to put in the liver. Let's just say it's going to be a CKLM, right? Where are we going to stage these patients? So of course, because in the CKM, there's stage 4A and 4B. 4A is if the patient doesn't have end-stage kidney disease, and 4B if the patient has end-stage kidney disease. So if we're going to put liver in there, 4A is liver cirrhosis compensated. 4B is liver cirrhosis uncompensated. And stage 3 is if you already have F2 and F3, because that's when you really need to act to prevent it from going to liver cirrhosis. Same thing with the subclinical coronary artery disease and subclinical heart failure. Makes sense. That's when you become more aggressive. And stage 2 is when you have S3 and you already have the inflammation or steatohepatitis. Stage 1 is when you have S1 and S2. And at stage 2 is when you already have stage 3. And for me, it makes more sense because the treatment is pretty much the same. If you already have subclinical disease, that's when your GLP-1 receptor agonist and SGLT2 works really, really well. So for me, it's perfect to just put that liver staging in the CKLM construct.
Can I ask you a question about that?
Yes.
Would you be able to use the current classifications that you've got, the stage 0 to 4, and then subclassify a population using either MRI, PDFF, FibroScan and CAP to see what the actual subclinical steatotic levels were within those groups, to be able to further define exactly where you are? Because your stage 0 fit, healthy person, we know that 30% of them have subclinical steatotic liver.
Yes.
So if you could define what that definition was, so if you start at a base of normal people have a 30% steatotic liver prevalence, but no other symptoms, then you've just got to build. And we know that.
So they go to stage 1. So you can restage them. Now you think that, and that's the thing is it becomes personalized. It's not just about the weight. It's about what's going on with your organ. And for me, that is more fair to the patient because that's really what's going on. And it's just like the BMI, right? BMI is normal, but then your fat percentage is high. So something like that. You're right. We can actually use that.
And I think we can also use FIB4 as a predictor, can't we? Because the higher the FIB4, the lower the estimated GFR, for example. There are areas where it does sort of match. So again, we can use other assessments that we already have in primary care that can be utilised to say if the GFR or if the FIB4 is above this, then you need to be checking kidney function as well and looking for those. So there are signals within the disease, crossovers. I'm going for the L. Add the L.
If only we can make some like votation or something. But that doesn't work. So hopefully at some point they will change their mind. It doesn't really matter. Like for me, even if it's officially that's how you stage it, when I talk to my patient, I put that in there. And another important thing is by staging these patients, this is where Life Essential 8 comes in. And I tell my patient, so if I explain it to them, it's like an analogy. So life is like a journey, right? We all get into our destination, which is a stage 5. But the problem with getting to our destination, we don't want to get there really quick. We want to not to get there as much as possible. But so I tell them that the Life's Essential 8 is like our cruise control or a speedometer. If the higher your score in your Life's Essential 8, and I tell them it's essential, it's not optional. So the higher your score, the smoother your drive and the slower your drive is. And the lower your score, the faster you are. And I can put in there, if you're smoking, it's like you add additional 20 miles per hour or something like that. If you don't exercise, another 10. So it's important to know. And if I have a 30-year-old patient and they already have a high blood pressure and I tell them them you're already on stage 2. Remember, you don't want to get to stage 5 really quick, so you might want to slow down. So how do you slow down? So you follow the Life's Essential 8, and if doing that, your blood pressure is still high, then we need to give you more. Then maybe we need to give you blood pressure medication, so you slow down a little bit. Same with the cholesterol. If they already have subclinical disease and they don't want to take their cholesterol medication, so I tell them you're already on stage 3. You don't want to get to stage 4. So how do I slow down? These are your meds. Our goal is to lower down your LDL to less than this, and this. You need to do all the Life's Essential 8. So now it makes more sense. We don't just tell them exercise and eat less. It makes more sense to me. We don't just give them a pill. Now, the communication is much better.
And is there a genetic link, like as there is in liver? Liver cirrhosis runs in families, the genetic link to be more damaged and things like that. Because our patients respond very well to knowing that protecting their livers or helping themselves actually helps their family and becoming more liver friendly, which is kidney friendly and heart friendly and things. So do you have that strong genetic seed?
So when I talk to them, it's not really part of that. But when I talk about genetics, just like Lp(a), so they have that underlying, they're born like they're already running faster, right? So they need to work harder to put that brake. So that's how I explain it to them. And same thing as screening for cancer. I tell them we screen you for cancer because if you already have a cancer, it takes you out of that route and put you on a speedway or something like that. So genetics is, I talk to them about that too.
Interesting. If you add L and you go to CKLM, one of the things that clearly happens is you start to think about the liver as being two-dimensional, right? I mean, one of the things Jorn Schattenberg was talking about in an episode that will appear shortly before this one is the idea that over time, we're going to start looking for liver therapies that have two elements, one being metabolic and the other being liver-centric. You know, maybe a GLP-1 plus resmetirom to give you the most obvious example today. I didn't see anywhere in the document or what else we've talked about any attention to resmetirom at all. I guess that's because there's no L in CKM, right?
There's no resmetirom yet during that time. Remember, that was 2023.
All right.
So there's no resmetirom during that time. And on that journal too, if you're going to look there, they talked about screening, but they didn't really talk about treatment. They stopped with screening patients for fatty liver, and that's it. And they didn't put that in the diagram. They just mentioned it. You mentioned about the metabolic. So if you're going, you know what we're doing right now already. You know the studies like the ESSENCE study. So the GLP-1 receptor is the foundation of the CKM construct. We want to lose weight. We want anti-inflammatory. We want cardioprotection. We want renal protection. Well, the GLP-1 has cardioprotection. The GLP-1 has renal protection. It prevents you. It's a prevention for heart failure as well. But we know that in patients who have fatty liver, we use the GLP-1 to shrink the fat as well. And we do have information now that it's telling us that it's shrinking fibrosis as well. So you are treating the same disease on the same, if you put the L in there, you potentially can be using the same medication too, plus the resmetirom. Now with the kidney too, so we talk about the SGLT2 inhibitor, which is also cardioprotection, renal protection, prevention of heart failure. It also has a role in removing the fat in the liver. So all these medicines has an effect on the liver as well if you put the L in there. But when you go to the heart failure, right, the heart failure, they have medications, and CKD, they have medications like what we call non-steroidal MRA, which is the finerenone. It's not cardioprotective. It's just specifically for prevention of, it's just for heart failure. So if you put resmetirom there, then that's going to be liver specific. So there are medicines that are kidney specific, heart specific, and liver specific, in addition to those other medications that can take care of those three organs.
I'm so busy listening that I just had a thought that went right out of my head. I guess I'm getting old. Louise, you got a question or comment?
Yeah, well, you think about what you were going to say. So if we put the liver back in, it means that, or we put the liver into the conversation and we put it into the definition, it does mean to me, or it appears to mean to me, that doctors will look at the effect of the medications they use, not only just on the kidney or the heart, but they will actually look at the role of what it's done to the liver within that, which is currently ignored.
Yes.
We see a lot of medications, as you've said, that defat the liver, for example, but nobody's bothered about the liver. They're just looking at liver function tests, which don't tell us really that much on that sometimes. So that is a really good way of getting a holistic assessment of what the medication is actually doing to the individual. And if the liver is cirrhotic, it's not going to do those medications much good or be as beneficial as it could be. So therefore, the assessment of the liver to know whether your medication is working appropriately or is going to is actually an important part when you go back to your stratification of 0 to 4, because you've got less likelihood of like that. So there's lots of reasons to put L back into that conversation. And when you were talking there, the other question that came to mind was PNPLA3. We know it's a genetic, it loads fat to the liver for some of the people, or predisposes them to doing that, but it is cardioprotective. What is its role in CKM? Do we know yet?
I don't think that we know a lot about that, but this is, so I did my genetic testing, and my PNPLA3 gene puts me at higher risk for hypertriglyceridemia, puts me at higher risk for insulin resistance. That is my risk for diabetes. So it actually increases your cardiovascular risk. And I don't think it is cardioprotective, but like you said, you might have heard another article, but I think there's still a lot to learn more about this genetic problems. The causality, is it causal or what? I actually have a patient that is homozygous for PNPLA3. He does have mild steatosis, but no cirrhosis. But I've had some patients wherein heterozygous and no fat, but it all goes back to, is that gene turned on or turned off? Does that patient have what we call the second hit? And I think in all genes, the most important is the second hit. What we mean by the second hit, for example, Lp(a). The patient is not smoking, so the patient is eating healthy, so the cardiovascular disease is less. But the patient that has Lp(a) and smoking and really unhealthy diet and not exercising, that is the one that's going to turn that gene. That's what we call second hit, and that's the one that's going to have all those multivascular disease, even if they have both elevated Lp(a). I want to circle back to your question about the GLP-1 in the staging. So I had this provider that made a comment, well, I don't need to measure the liver, I'll just treat it. The GLP-1 receptor agonist is going to help it anyway. But when you treat a patient with heart failure, don't you measure the ejection fraction? When you treat a patient with SGLT2 inhibitor, do you recheck the urine albumin creatinine ratio? How do you know that it is enough? So in the liver, how do you know that your GLP-1 receptor is enough? When would you know to put in the resmetirom in there? So that's why it's very important to measure and treat. So the problem really too is sometimes if we don't measure it, we don't really treat it, right? Like we don't measure it. But sometimes we measure it and we don't treat it. That's what we call therapeutic inertia. And I think that's why education is really important, when to act and not to act, and the things that we measure.
Louise, I think you found a kindred spirit.
We are twins.
From another, from the different continent.
Yes, but I do think that you know that, in fact, everybody who listens to me knows that I sing from that sort of holistic type of thing. But I think it resonates with patients, because if we just keep independently telling somebody, you've now got heart disease, you've now got kidney disease, you've now got diabetes, they believe they're all separate systems. And they're not. This is a metabolic domino. And if we link them all together, then people can actually understand, rather than that feeling of, don't tell me I've got something else wrong with me. What Emily describes is that conversation where you can say you're on the pathway and these are different bus stops that you might get off at, or you might go straight past and collect. Like the Monopoly board, you want to buy some of these properties. These are things you don't want to buy. You want to leave them on the board realistically. And I think this visualization...
Please send me to jail. I don't need the $200. I don't want to buy boardwalk. Send me to jail, yeah.
Yes, but it makes conversations easier because people don't want to be told they've got another disease. If they feel it's all part of the same system and they can make a difference to that, behavioral belief therapy comes in. I've got something I can change. Whereas if you're telling them retrospectively, you've now got kidney disease, and that you don't link it to the heart or you don't link it to the liver, it's very difficult for people to just grasp that sometimes, that they're all part of that same metabolic.
I'm visualizing two things, right? First of all, if I tell you that you've got heart disease and kidney disease and liver disease and obesity and maybe hypertriglyceridemia, man, that's 5 things I got to fix.
Well, if you can fix one thing, makes a big difference, even just for one.
Well, wait, but correct. But if they're all part of the same syndrome, so that by fixing one, I'll have an effect on the others, that becomes better.
So just like what I said, that can hypertriglyceridemia, if you decrease the fat in the liver, then that prevents your liver from forming more triglyceride, right? The de novo lipogenesis. So GLP-1 can treat that. GLP-1 can treat, it's a heart medicine. It's a kidney medicine. So the patient's going to be more motivated. But can I take this opportunity to, I know we're going to say, so how are we going to move the needle? And I think American Heart Association is leading us in the right direction. So this is what I'm allowed to talk about, the CKM Health Initiative of American Heart. So let me just read it to you.
Yeah, please go ahead.
So American Heart Association launched the Cardiovascular Kidney Metabolic CKM Health Initiative in 2024. This initiative focuses on a holistic, patient-centered approach to addressing CKM syndrome, which involves heart disease, kidney disease, diabetes, and obesity. As part of this initiative, the AHA is developing a CKM recognition program for healthcare professionals and health systems dedicated to improving CKM care. In collaboration with the Cardiometabolic Center Alliance, the AHA will also develop a scalable, patient-centered certification framework to improve treatment for CKM syndrome. So we are piloting, the pilot site testing is likely to begin soon. And for those who are interested to be a part of that, watch out for that announcement at the HA scientific session in November. So what they're doing is trying to elevate that knowledge, because if I want a certification, I want to be recognized for this. And I think people want recognition, right? And this can help elevate that care for CKM patients.
Very cool, very wise.
There's somebody with a FibroScan in there, they can measure what it's doing to the liver as well.
Yeah, they're actually going to be including the liver evaluation there as well.
So if I were a physician who wanted to be part of this,
yes,
what would I do?
So you look at the website, American Heart Association, and they're going to send out invitation. For example, so what we're doing is if you're interested, you reach out to us and one of us will be reaching out and will be your contact person. So if we want a cardiometabolic hepatology to be a part of this, they can reach out to me. They can reach out to me too, or they can reach out to AHA, but we have point persons that can assist them.
Excellent. Very exciting. Okay, Louise, what do you want to ask that we haven't hit so far?
Well, I just wanted to touch it, and I wanted Emily's view. There was an article recently released called The Burden of Cardiovascular Events According to Cardiovascular Risk Profile in Adults with High-Income, Middle-Income and Low-Income Countries, the PURE, a cohort study. And the frightening thing about that was over 40% of the first cardiac events happened in the low-risk group. But when I was sort of reading that article, what struck me was there was a real notable mismatch between the traditional cardiovascular risk scores and the outcomes, not dissimilar to what we observe in patients with MASLD. There was an inverse patient risk in low and high-income countries, consistent also with what we see in MASLD, where low-income countries often carry a disproportionate burden when they are affected. Female age dominance, increasing event rate, closely mirrored. Masood, MASH and steatotic liver disease trends. And it was one of those things of when you were discussing earlier about this cardiovascular and kidney and these earlier rates, and what we're seeing is the elephant in the room appear. It's not something being considered in those low risk groups. As I alluded to earlier, if we just take the average population, risk 0, who have undiagnosed steatotic liver disease, are we then able to look at these things within the sort of welcome event that you've just announced at the American Heart, and to get to these really concerning figures that 40% of all first cardiac events happen in the low risk group, we're really missing something.
Because they're considered low-risk groups because they were not evaluated. That's one thing. They were not fully evaluated. For example, ASCVD risk calculator. That doesn't include the family history. That doesn't include. So let's just say, okay, I'm a 40-year-old patient, Southeast Asian. You calculated my ASCVD risk score and it's only 2%. But you didn't know that I have a significant family history. You didn't know that I have ASCVD. You didn't know that my BMI is 23, but as a Southeast Asian, I already have significant fatty liver disease. And then you didn't do my heart scan, and you look at my LDL and it just says 120, my blood pressure is 130/80. I look low risk to you. But we have what we call SMRF list. That's the standard modifiable risk factor, which is the blood pressure, the lipid, and the blood sugar. Non-standard modifiable risk factors are what we call LP(a), hsCRP, which is inflammation, which is correlated with if you have fat in the liver, you are inflamed in the liver, your hsCRP goes up, and your cardiovascular risk goes up. So most of the time, that's the highest risk compared to someone who's 60 years old and the blood pressure was 170/100. They're more aggressive with that patient because it's really, really high. LDL of 170, they treat them, but those ones who are considered normal, look normal like me, are actually at highest risk. And that's the purpose of this ASPC, is you need to look deeper.
So wait, is it that you're at highest risk, or is it that because your risk is going to go unidentified?
Unidentified. That's the problem there, is they go under the radar because no one looked and no one investigated further because you look fine. I look fine, and until I have a massive heart attack.
Yeah. See, that's the interesting point, though, which is that we're now good enough and we have enough tools at our disposal. We don't have to use, we used so many artificial cutoffs, right? Because we didn't have the stats and we didn't have the numbers. So one of the things we find ourselves more and more falling into is the idea that when NITs take over, when NITs become the predominant diagnostic for a liver, you're not going to be talking about F1, F2, F3, F4 anymore. You're going to be talking about CAPS. You're going to be talking about KPA scores. You're going to be talking about percentage liver fat. You're going to be talking about a bunch of things that are going to be derived from tests that will present a more holistic picture of the liver than simply what you get out of one biopsy.
True.
By the same token, we don't need cutoffs right now. We need kind of what you're describing looks to me almost like an equalizer, right, on a sound studio. You got these 5 different bars. They go up and they go down. And if they're high enough that they're producing a sound and the sound is out of whack, treat it.
Mm-hmm. Yes.
And we have the tools to get there. We don't necessarily have the education to teach the tools, but we have the tools to get there.
But we're not using them.
No, we're not yet.
Not yet.
Yeah.
Not yet.
But you keep preaching it because you're doing great.
Well, I'm trying to. There's still a lot to learn. There's really still a lot to learn. And it's really hard to, if you're going to look at it, we've been practicing medicine like this for a long, long time, siloed, and numbers. We stick to the LDL. Normal is less than 130. If you don't look for the calcium score, the heart scan, you will not know that 120 is not good for that blood vessel. But like I said, I think one of the biggest hurdle is lack of awareness, both from the patients and healthcare providers. We've operated in the silos for too long, and it's it's really hard to dismantle those walls. But I think we're on the right direction. We're on the first step, and I think we're going to get there.
That's encouraging. And I think if we all want to help the holistic patient, we all want to get there. And it's where you potentially then, the people aren't necessarily on the same page. It's got to be cardiology. I don't mind who leads it, as long as the patient gets the best care.
That's the truth.
And I think
a lot of it's going to come from the bottom up, not the top down, right? It isn't a question of what somebody writes on the top down. If I don't organically understand it, I'm not going to do the right thing.
True.
Emily, this has been fantastic. We'll have you back in 3 more months just to catch up again.
Sure.
But these have been great sessions.
And I'm so excited to be chatting with Louise. Oh, my goodness.
Well, I'm in the US next week, so that'll be fun. I'll be in your time zone.
Next time we'll get Jorn. The first time you were with us, it was just you and me, and you were so excited to be on the podcast. Now we got you up to Louise. We'll get Jorn the next time.
I want to be with Dr. Noureddin. Okay, that's my request. If I can be with Dr. Noureddin, I'll be really, really happy too. So I got my first goal. That's my second goal. Okay.
So that's great. And thank you so much.
Okay, thank you. It's a pleasure.
On behalf of the surfers, our guests, and our sponsors, Regeneron Pharmaceuticals, LiverRight, and Talazun Health, thanks for joining us this week.
Please join us again next week when we share Louise's and Roger's choices for the big story of the first 6 months, plus an interview from The Vault, your favorite and most listened to from among our past year's episodes.
And until next week, stay safe, surf on, and we'll see you again on Surfing Next Tsunami Podcast. Bye-bye now.